Hello, my name is Vilma Callejas, and in this presentation, we will be presenting an unfolding case study on osteoporosis. Client 1, Day 1. Client presentation. Inés Villegas, a 52-year-old Hispanic female who was brought to the emergency room by her husband, Carlos Villegas, after falling in her shower. She reported to be in good health and had no comorbidities, but history shows that she leads a relatively sedentary lifestyle and having a 15-year history of cigarette smoking. She does not take any medications except for metoprolol for hypertension, which she states non-compliance. She states she fell upon entering the shower when her right leg slipped out from under her. She landed on her left hip, and she states to be in excruciating pain in her left hip. Background and medical history. Mrs. Villegas lives with her husband and no kids live in the home. She states her husband works in construction and that she does not work and stays at home. She has a history of hypertension and obesity. She states to be non-compliant with her blood pressure medications due to the lack of money. She also states that she tries to eat healthy, but since healthy food is more expensive, she cannot eat healthy all the time. She said she tried to lose weight, but it's harder because of her obesity and her feeling tired all of the time. Question 1. What risk factors does Mrs. Villegas have for osteoporosis? What parts of the skeleton are more prone to break in someone with osteoporosis? The risk factors for osteoporosis that Mrs. Villegas have are being a female, older age, she already experienced menopause, history of obesity, smoking, and living a sedentary lifestyle. Bones that are more prone to break due to osteoporosis include the hip, the wrist, and the spine. These are called femurs, carpals, and vertebral columns. Physical presentation. Patient is alert and oriented times 4, with some agitation noted. Responses are appropriate to questions being asked. She states to have hit her head when she fell as well, and there is bruising noted on her forehead, but she denies having any headache. There is no signs of trauma in neck, torso, arms, and right leg. External rotation, adduction, and shortening of the left leg noted. Left leg is tender to touch, and movement is now stabilized with a splint. Heart and lung sounds are within normal limits. Initial survey. As a nurse, you do an initial survey and the results are as follows. A. Airway. Within normal limits, no signs of obstruction. Breathing and ventilation. Adequate movement of air into lungs. Lungs are clear. Circulation and hemorrhage control. Adequate circulation, capillary refill of less than 2 seconds on all extremities, and no signs of bleeding noted. Disability and neurologic assessment, neck brace in place and Glasgow scale rate of 15. Exposure and environmental control, bruising on left leg, hip, and forehead. Her current vitals are blood pressure 146/86, temperature 99.7 degrees Fahrenheit, heart rate of 102, respiratory rate of 22, and O2 saturation at 100 on room air, and pain level of 10 on a scale from 0 to 10. Question number 2. Based on client presentation and physical assessment, what interventions are priority for this patient and what is concerning regarding her vitals? Priority for this patient is to keep her left leg, hip, and head immobilized before a head or neck injury is ruled out. Her elevated heart rate and respiratory rate is probably a result of her pain. Patient is in excruciating pain, so pain medications are to be administered per provider's orders. Her elevated blood pressure is not of concern right now, and it is expected since she does have a history of hypertension and she states non-compliance with her medications. Question 3. What orders and diagnostic tests do you expect the provider to order? The provider's orders are as follows. An injection of oxymorphone hydrochloride 20 mg every 4 to 6 hours as needed to relieve pain. Metoprolol extended release tablets 50 milligrams daily for blood pressure. Lorazepam for anxiety 3 milligrams tablet one-time dose. X-ray of her left leg and hip and neck. A DEXA scan, a CBC, and a CT scan. CBC lab results are in, and they are as follows. A glucose fasting of 88, a creatinine of 1.2, cholesterol 193, LDL 185, HDL 31, WBCs of 8,000, RBCs of 4.4, hemoglobin 11.5, hematocrit 40%, and platelets 148. End of day 1. Client 1, day 2. Next day is in. Patient's pain has been responding well to medications. Her anxiety has subsided, and she is now waiting for her doctor's diagnosis and plan of care. These are her most recent vitals, and physical assessment findings are as follows. Vitals are blood pressure 128/78, temperature of 97.9 degrees Fahrenheit, heart rate of 87, respiratory rate of 18, O2 saturation of 100 on room air, and pain of 3 on a scale from 0 to 10. Her assessment findings are general appearance. Patient is calm and well groomed and has a worried appearance. Respiratory rate, clear lung sounds upon auscultation. Respirations are regular and unlabored. Cardiac within normal limits. Heart rhythm is regular and no signs of cardiac issues. Pulses are present. Pedal pulses are +2 and radial pulses are +3. Neuro. Alert and oriented times 4. Able to follow commands and answers questions appropriately. GI. Bowel sounds are active in all 4 quadrants. Genitourinary are within normal limits, and skin appropriate for ethnicity, warm to touch, with bruising on the forehead and on right leg and hip. Question 4. Her provider ordered an X-ray, a DEXA scan, and a CT scan. What do you think will be the results of this diagnostic test from her clinical presentation? Results are in, and they are as follows. So the X-ray of the left hip revealed a complete comminuted intertrochanteric fracture of the right hip. No other fractures were noted in the right leg. There were also long-term osteoporotic changes in the femur, tibia, and fibula. The DEXA scan showed a T-score of -2.5, revealing severe osteoporosis. So the T-score, it reveals the bone density. A CT scan, negative for bleeding. As the nurse, a normal CT scan is reassuring, but it does not mean that the patient will not have a brain bleed later on. So this type of brain bleed would be called a chronic subdural hematoma, and this is why it emphasizes the importance of performing frequent neurological assessments even though you already had a negative CT scan, because you don't know if the patient might bleed later on. Question 5. Radiologists reported a complete comminuted intertrochanteric fracture of the right hip. What does this mean? A complete fracture is one where the bone is completely separated into two or more pieces. The bone is not simply cut onto. In this case, the bone is fractured in multiple irregular shaped pieces because it is a comminuted fracture. The fact that it is intertrochanteric gives us the location. Trochanters are found on the proximal portion of the femur, and the inter indicates between, so the shattering occurred near the neck of the femur between the trochanters. And over here down on the right, you can see the location of her fracture. Providers' orders are as follow. Continue pain medication with oxymorphone hydrochloride. Continue with blood pressure medication, metoprolol 50 mg daily, and administer alendronate 10 mg daily for treatment of postmenopausal osteoporosis, oral calcium supplements, and oral estrogen. Question number 6. Explain how alendronate or Fosamax, calcium, and estrogen helps to treat osteoporosis. The alendronate or Fosamax works by binding very tightly to the bones and preventing the calcium from being removed by the osteoclasts. This helps the osteoclasts from breaking down the bone, which helps to keep the bones strong and less likely to break. The oral calcium supplements increase the calcium ions available in her bloodstream, which make it easier for her osteoclasts to use it to build new bone. To use this calcium in the bloodstream instead of digging into the bone and taking the calcium from the bones, which will make them more fragile. The oral estrogen will excite the osteoblasts and make them more active, thus taking calcium ions out of the bloodstream and building new bone, as was just discussed. So even if you were just to give them oral estrogen, calcium supplements in her diet, all of those are important. They all work together to prevent the fast breakdown of the bone. Continuation of care. Patient is scheduled for a hemiarthroplasty due to her complete comminuted intertrochanter hip fracture, and you get a new set of vitals before surgery. Fasting glucose of 88, creatinine of 1.2, cholesterol of 193, LDLs 185, HDLs 31, WBCs of 8,000, red blood cells of 4.0, hemoglobin of 10.5, hematocrit of 39%, and platelets at 149. Question 7. What is concerning regarding Mrs. Villegas' lab values with the fact that she will be going into surgery soon? Any surgery comes with risks and complications, and in this case, Mrs. Villegas' labs that are concerning are her hemoglobin, hematocrit, and platelets. Her results are relatively lower, and during surgery, it is possible that she may become anemic due to blood loss and need a blood transfusion. Blood loss can result not only from the initial fracture, but also from the operation, and it can remain hidden for a period even after surgery. Her platelets are low as well, meaning that she has a higher risk for bleeding during surgery. End of day 2. Client 1, day 3. Mrs. Villegas is backed to the floor after her hemiarthroplasty surgery. She appears drowsy from the anesthesia, but can answer questions. She is oriented to place, person, time, and self, and complains of very little pain. Her radial pulses are +3 bilaterally, and pedal pulses are +2 bilaterally. Lung sounds are clear, and respirations are regular and unlabored. She was left in her room to rest with her husband. And when she comes back from surgery, you take her vitals, and they are as follow: blood pressure of 129/72, temperature of 98.9 degrees Fahrenheit, heart rate of 82, respiratory rate of 16, and O2 saturation of 100 on room air, and a pain of 2 on a scale from 0 to 10. And over here down on the right, you also see a picture of an x-ray of how the new bone will look after the hemiarthroplasty. So it's kind of like a partial hip replacement. Providers' orders are as followed: hydromorphone 0.25 mg IV every 2 hours as needed for pain. Ondansetron 4 mg IV every 8 hours as needed for nausea, because after the anesthesia they may experience nausea. Clopidogrel 75 mg by mouth daily for deep vein thrombosis prophylactics. Lactated Ringer's infusions IV at 120 mL per hour. Sequential compression devices, and you want to apply those continuously, and you have a picture of it here on the right of how that device will look. Incentive spirometer for prevention of post-surgery pneumonia, and there's a picture up here on the right as well. And deep breathing and coughing every 8 hours or as needed while awake. And the incentive spirometer and the deep breathing and coughing are both for the prevention of pneumonia, which is one of the most common complications after surgery for these patients, especially if it's a hip surgery. It's kind of a large bone, so they have less mobility, and we want them to get those lungs moving. That's why we encourage the deep breathing and coughing and the incentive spirometer. And you would also show them how to use the incentive spirometer as well. It depends on the provider's orders or what they were already able to do on the spirometer, but usually it's above 1250, and you want them to get to that 1250 or more if they can, and stay on a certain like hover the little ball on that certain number. That way you know they are able to expand their lungs effectively and move those secretions and prevent post-surgery pneumonia. Question 8. What are some complications that Mrs. Villegas is at risk for due to being post-hemiarthroplasty surgery? The complications that she would be at risk for would be infection. The chances of developing an infection following a hemiarthroplasty are about 1%, but if it does occur, this complication can be very serious. Infections can spread to the rest of the hip, potentially requiring another operation. She is also at risk for blood clots or DVTs, and any operation on the hips or legs raises the risk of a blood clot from forming in a large vein or deep vein thrombosis. If the clot is large enough, it can block circulation in the leg, and a clot may also travel to the lungs, which would be called a pulmonary embolism, and can cause serious heart and lung problems. Getting up and moving your legs as soon as possible after surgery is one of the most effective ways of preventing deep vein thrombosis. She is also at risk for a dislocation. If the ball slips out of the socket, it's called a dislocation. It's most common soon after a hemiarthroplasty, while the connective tissue in the joints is still healing. So your doctor will give you education on not bending your hip, and you would also have to go with a physical therapist so you can get that movement back of your hip without having a dislocation. New assessment findings. 2 hours after Mrs. Villegas receives her morning medications, her husband calls the nurse stating, "My wife can't catch her breath." Upon assessment, diminished breath sounds are noticed. Heart rate is 120, respiratory rate of 26. Her respirations are regular but labored, with hemoptysis noted. She reports a sudden sharp pain in the chest, and her O2 sat is now at 86% on room air. Question 9. After your assessment findings, what are your nursing priorities, and what do you expect the provider to order? Nursing priorities is to administer oxygen therapy, assess for signs of hypoxemia, and monitor the pulse oximetry values and report findings to the healthcare provider. As for the expected course of action, the healthcare provider may order a D-dimer, a chest X-ray, ultrasound, angiography, ABGs, BNP, and cardiac enzymes. He ordered those results, those lab, and these are the results. ABGs are as followed: a PCO2 of 30, PO2 of 66, and a pH of 7.48, revealing respiratory alkalosis. Chest X-rays show atelectasis in the right lung, and patient is diagnosed by the provider with pulmonary embolism due to a DVT. The patient is placed on a nasal cannula at 4 liters. And these are her current lab values. Glucose fasting of 88, creatinine 1.1, cholesterol 193, LDLs 185, HDLs 31, white blood cells of 9,000, red blood cells of 4.4, hemoglobin of 12.1, hematocrit of 40%, and platelets at 149. The provider also orders chest physiotherapy techniques that will help in breathing deeply, this in order to help expand the collapsed lung due to the pulmonary embolism, surfactant therapy to help prevent further alveolar collapse, and heparin loading dose of 500 units IV injection, followed by 20,000 units infused per 24 hours. And the patient would also be going on warfarin or Coumadin following discharge. Question 10. Now that the patient is on anticoagulant therapy, what are some nursing interventions that should be done frequently? Some of the priority nursing interventions for a client who is on anticoagulant medications are monitoring vital signs for indicators of bleeding or hemorrhage. These vital signs would be like tachypnea, hypotension. Tachycardia may also be associated with bleeding or hemorrhage. This can occur with anticoagulant therapy and would need prompt intervention. At the minimum of every 6 hours, inspect for any wounds that may have resulted from invasive procedures. If there is any abnormal bleeding, notify the provider immediately. In this case, it would be her hip incision. If the patient is on heparin, monitor the partial thromboplastin time, or PTT, to ensure therapeutic ranges. Therapeutic ranges would be from 1.5 to 2.5 times the normal range. And if patient is on Coumadin, you want to monitor the prothrombic time, PT, or INR to ensure the patient stays within the therapeutic levels. Therapeutic levels for warfarin on INR would be 2 to 3.5 times the normal range. End of day 3. Client 1, Day 4. You have new assessment findings. So Mrs. Villegas has been responding good to the treatment for pulmonary embolism. Lung sounds are clear but slightly diminished, and respirations are even, regular, and unlabored. No shortness of breath or agitation noted, and heart sounds are within normal limits and normal sinus rhythm noted on the monitor. Her right hip surgical dressing is clean, dry, and intact, and she denies any pain. Pedal pulses are +3 bilaterally, and radial pulses are +3 bilaterally. The provider orders another chest X-ray, and results are negative for atelectasis, and there is still a small blood clot present. We take her vitals, and her current vitals are blood pressure of 122/69, temperature of 97.9 degrees Fahrenheit, heart rate of 77, respiratory rate of 16, O2 saturation of 100 on 2 liters nasal cannula, and pain is 0 on a scale from 0 to 10. Question 11. What medications do you believe help to resolve the pulmonary embolism, and how do they work in the body? Chronic anticoagulation is critical to prevent relapse of deep vein thrombosis, DVT, or pulmonary embolism, PE, following initial heparinization. Heparin works by activating antithrombin 3 to slow or prevent the progression of DVT and to reduce the size and frequency of PE. Heparin does not dissolve the existing clot. The one that would dissolve the existing clot is the thrombolytic therapy, which they can use alteplase for that. But in this case, she had a small clot, which gave her some respiratory symptoms, but not heart symptoms. It wasn't big enough to create heart problems. And if they were to do a thrombolytic therapy with alteplase, it would bring more risk factors. So it's a very small blood clot. And with the heparin, it'll eventually dissolve on its own, and the heparin would help it would keep it from becoming bigger. A pulmonary embolism causes obstruction to the pulmonary circulation. The body sends a signal to the release of neurohormonal substances and inflammatory mediators, which cause vasoconstriction. Increased pulmonary hypertension occurs. The absent blood flow to the affected lung segment causes ventilation through perfusion mismatch and a decrease in surfactant production by the alveoli that help them expand during inspiration. This results in atelectasis and further worsens hypoxia. If the embolus is large enough, infraction of the lung tissue, dysrhythmias, disease, decreased cardiac output, shock, and death are possible. Surfactant therapy helps by counterbalance the wall tension of the alveoli and thereby protecting the lungs from collapsing. New providers orders warfarin initial dose 10 milligrams daily, twice a day by mouth for 4 days, then proceed to 10 milligrams tablet by mouth for 3 months. Concurrently, you will be taking low molecular weight heparin, enoxaparin or Levonox, 1 milligrams per kilogram every 12 hours subcutaneously for 7 days. And continue metoprolol extended release tablets, 50 mg daily for blood pressure, oxycodone hydrochloride tablets, 10 mg every 4 hours as needed for pain, sodium docusate, 50 mg tablets daily to prevent constipation. And this is most likely, the constipation is going to be most likely due to her immobility and the use of the oxycodone hydrochloride, because it is an opiate and it does tend to cause constipation. So providers would prescribe sodium docusate, which is a stool softener. to prevent that. And he orders wean-off oxygen therapy as tolerated by the patient. And he does order some labs, PTT, PT, and INR. So you do your lab, you check your lab values, and they are as follow: glucose 88, creatinine 1.2, cholesterol 193, LDL 185, HDL 31, white blood cells of 9,000, red blood cells of 4.4, hemoglobin of 12.2, hematocrit of 40%, and platelets of 150. You also check your uh, partial thromboplastin time, which is 1.6, your prothrombin time, PT 12 seconds, and INR 1.5. Question 12. After reviewing the provider's orders, what is the purpose of administering enoxaparin or Levodox with warfarin or Coumadin concurrently, and what lab values would you monitor? Heparin and warfarin are taken concurrently at first because of the delay in factor II prothrombin suppression. Heparin is administered concurrently for 4 to 5 days to prevent thrombus propagation. Loading doses of warfarin are not warranted and may result in bleeding complications. So heparin or low molecular heparin should be administered with warfarin initiation and continue until the INR has been in the target therapeutic range for a minimum of 24 hours. Therapeutic INR levels are 2 to 3.5 times the normal level. Update. Patient is now at 100% O2 sat on room air. She tolerated well the oxygen weaning process, and she is now on her on 2 days post-op, and you have orders for discharge. Right hip incision dressing is clean, dry, and intact. Last full physical assessment is within normal limits, and her vitals are stable. She expresses concerns regarding her dressing and how she can take care of it at home, and you educate her on medications that she will need to take home and continue taking for the next 3 months. She expresses concerns regarding her ability to pay for these medications. Question 13. Regarding Mrs. Villegas' concerns about her ability to pay for the medications prescribed by the provider, what community resources can you offer her? What kind of education would you give Mrs. Villegas regarding her post-operative care? Regarding her financial concerns, you can refer her to a case manager who will provide her with the most accurate information regarding medical expenses assistance. You can also tell her about patient assistance programs or PAPs. There is help available for many people who can't afford their medicines. These programs, frequently called patient assistance programs, are designed to help those in need to obtain their medications at no cost or very low cost. Regarding her post-surgery care concerns, you can assure her that you will be giving her detailed information about her recommended post-surgery care. You will be providing information about wound care, physical activity recommendations, pain management, precautionary measurements after surgery, and when to call the provider or emergencies, and a phone number to call in case she has any follow-up questions and concerns. Mrs. Villegas is now stable and ready to be discharged. Patient education and discharge paperwork will be provided, as well as a post-operative appointment in 2 weeks from now. End of case study. These are my references for the case study.